Hi everyone. On behalf of UCLA Health and the Leukemia Lymphoma Society, it's my pleasure to welcome you to the first session in the 2019 Closer to a Cure Community Lecture Series. Today we're joined with Dr. Gary Schiller, Professor of Medicine in the Division of Hematology and Oncology at UCLA Health, and Dr. Patricia Young, Clinical Instructor at UCLA Health. For this series, UCLA Health and the Leukemia Lymphoma Society will be visiting different neighborhoods throughout Southern California to provide education and updates on blood cancers. Blood cancers being leukemia, lymphoma, myeloma, myelodysplastic syndromes, and myeloproliferative neoplasms. In 2018, more than 1.3 million people were living with a blood cancer in the United States. And every 3 minutes, someone was diagnosed with a blood cancer. To date, there is no prevention for this type of cancer, so we're working hard to make sure that anyone who is diagnosed gets accurate and timely information, resources, and advice to make sure that anyone who is affected by a blood cancer directly feels confident about their treatment decisions and feels empowered to advocate for themselves and for their loved ones. So for the series, we have published the event dates in advance so that in hopes that you can attend in person, but we will have everything live streamed and archived in the UCLA website so that you can have access to advice from experts in the field in the comforts of your own home. So I'm thrilled to be able to have these guests here today to talk about the basics of blood cancers just to kick off the series, and also to address any questions that are front of mind for newly diagnosed patients. So if you have any questions, we really encourage you to ask them, there isn't any small or silly questions out there. If you're thinking it, somebody else is thinking it. So please go ahead and jot those questions down into the Facebook feed, into your YouTube feed, and we'll answer them as best we can. So we're going to go ahead and start with the basics, and Dr. Schiller, you can kind of kick it off. So what is blood cancer?
Well, most people, I think, use the term blood cancer to mean a cancer of the blood or bone marrow. The bone marrow is a large organ in the body, one of the largest, extending from the skull to the upper arms and upper legs and all the bones in between. And the bone marrow is making billions of blood cells a day. The bone marrow, therefore, can be involved by a cancer process, by a cell that becomes abnormal and gives rise to daughter cells and so on, as can the lymphatic system, which is the home of the immune system, itself derived from the bone marrow, but living in lymph nodes. So most of the time when people say blood cancer, they mean leukemia, lymphoma, multiple myeloma, and a variety of rare diseases that involve bone marrow or lymph nodes.
So myelodysplastic syndromes.
Myelodysplasia, myeloproliferative disease, histiocytosis. There are a lot of diseases that we take care of that fall under that kind of umbrella.
Gotcha. Okay. So what are the causes of these types of cancers?
Well, for the vast majority of patients, we don't know. Some patients have previous exposure to a DNA damaging chemical, so a benzene petrochemical, or to radiation, or they've had chemotherapy for another malignancy, which can induce changes in the DNA and can produce one abnormal cell that gives rise to millions of abnormal cells. But the majority of patients with one of these diseases has no cause that we can identify.
So, Dr. Young, are blood cancers contagious? Can you get them at the airport or anything like that?
No, blood cancers are not contagious. Blood cancers are caused by genetic changes, and so these are not contagious disorders.
Okay.
And no, you cannot get them at an airport.
Okay, good to know. What are the different symptoms for blood cancers?
So symptoms of different blood cancers can be caused by low blood counts. So a low white blood cell count can cause frequent infections. Low hemoglobin can cause shortness of breath or fatigue, and low platelets can cause easy bruising or bleeding. Usually the symptoms of blood cancers can be very vague. Night sweats, weight loss, changes in your appetite. So sometimes they can take a while to diagnose.
So if they present themselves like anything from the common cold, similar to a common cold, how are they then diagnosed as a blood cancer based off of those symptoms?
So usually symptoms are, they might not go away, or they might become more and more frequent, prompting patients to go to their primary care or even see a hematologist initially, and that leads to a workup and eventually a diagnosis.
And Dr. Schiller, is it common then for people to be misdiagnosed?
Well, it's not so common to be misdiagnosed, but there certainly is frequently a delay in diagnosis because the symptoms are very nonspecific. And certainly most patients who have fatigue have nothing to do with a blood cancer. So usually over time, as Dr. Young said, if there's a prolonged period of time in which patients have these symptoms, abnormal blood counts will be discovered, or on physical exam an enlarged lymph node or a big liver or spleen that will prompt then an evaluation that includes often a bone marrow biopsy as well as blood tests and other kinds of tissue biopsy.
Okay. So this is for both of you. If, for example, I was newly diagnosed and completely overwhelmed, where would I start?
Well, I would say you would start with a hematologist, hopefully somebody who could explain to you both the origins of the disease and the pattern in which the disease spreads or advances, and then talk to you about treatment. But I think that needs to be done sometimes over several sessions. I think the anxiety associated with the diagnosis could be so great that it might be better to split it up and first talk about what is the disease and then shortly thereafter talk about what is the treatment. Seldom do you need to do something immediately that day. And so there should be a chance to kind of get to know the patient, the doctor, and to learn something about the disease.
Right, just give time to digest it all. Did you have anything?
So I agree with that completely. I think that having a hematologist who can explain all of the diagnosis, the treatment, what's to expect, the prognosis even, and the treatment options. I find that patients can be very overwhelmed, and it's very difficult to get all of that information into one visit, and so it does take time for patients to fully understand. One of the things that I do refer patients to is the Leukemia Lymphoma Society webpage, because I think the information on there is very easy for patients to understand and gives a lot of very helpful information for both families and the patient themselves.
Okay. Based off of your experience, so if somebody you cared about, a loved one, was diagnosed with blood cancer, what questions would you ask an oncologist?
The natural question is there any reason why this happened? What is the connection with the environment? Most of the time we don't have an answer for it. And to describe something about what the disease does and what the treatment options are. But again, I think it pays to have some other resources available as well, written material, online material, and to give somebody a chance. It also helps a little bit to have a family member come along or a friend, because you have two sets of ears that are listening to what's going on. And it also helps if the hematologist is sufficiently experienced to kind of lay out different treatment options in something that is easy to understand and logical.
I do agree with that. Some of the points that you made are very good. Actually, having family members come to your appointment who can be a second set of ears and ask questions that might be very applicable that a patient might not think about during their visit.
Would you, based off of your answer, how important is it to get a specialist when it comes to blood cancers?
Well, I think it's pretty important because we're talking about diseases that are not terribly common. Now, lymphoma is more common, probably the most common of all of them, 50,000 cases, maybe 60,000 patients a year. But in acute leukemia, we have some leukemias where there might be only 3,000 patients diagnosed in the United States every year. And in that case, you really want somebody who has a lot of experience treating these diseases in a kind of focused specialty way.
How would you find these specialists, for care, and what characteristics would somebody look for in their healthcare providers?
I think one of the most important things to look for in your healthcare provider is not only the physician themselves, but it's a multidisciplinary team, down to the nurses, nurse practitioners who provide so much information and so much support, the specialists involved at that academic center, or any center really. So it's a multidisciplinary team of physicians and nurses and nurse practitioners. So I think that is very important to look for.
If somebody wanted to get a second opinion, how would they go about doing that?
Well, that should be relatively easy now. I mean, in the era of electronic records, there is a lot of sharing of records. It does help to have the records available when somebody comes for a second opinion. And so assuring that that has happened and that there's been a transfer of materials, that's important. And I think it's probably a good thing. You know, we live in an era where people have access to a lot of electronic information. And so if they go away from the Leukemia Lymphoma Society website or away from the National Cancer Institute website, you could find on Dr. Google a lot of misleading information. It's very challenging, and so it might be helpful when people get a second opinion to focus and to be directed in a way that leads the patient to a better understanding of disease and of treatment.
What would be sort of the steps of getting a second opinion?
First I would say definitely gather your records, and like Dr. Schiller was saying, nowadays electronic records are readily available. That's very important for your hematologist to review. That would be very important. Your provider can also refer you, or may know some contacts within your local community who might be able to provide a helpful second opinion. That might be a step as well.
And in regards to one of the questions that we get, if somebody's looking for a specialist, how can they be involved with their care if they're too far away, or maybe the specialist is out of network or something like that?
Well, we do sometimes do telephone consultation, external chart review. It's not as good as seeing the person. It's very hard to read a person's response, their understanding, their awareness, their anxiety when you're doing that through a phone. But we have done such things. Again, it probably is better not to do it that way. This is a small field in some ways. Cancers of the blood and bone marrow, again, they're not a huge number of patients. There are enough, as you described when you provided the introduction to this, but there are not so many, and so we tend to know one another. The practitioner community of hematologists, oncologists would know each other, and for every academic institution, there should be on their website very clear descriptions of what area of expertise the doctors have in what given area.
Okay. Good to know. Okay, so clinical trials. What is a clinical trial?
Well, clinical trials is a very big field, and can be, I think the easiest way to break it down is into clinical trials which are observational and clinical trials which can be interventional. And the idea of clinical trials is to evaluate a given drug or a new treatment and evaluate efficacy and potentially safety. And so clinical trials, I think, oftentimes patients think of clinical trials as the last resort, but I think that's a misconception, because we have clinical trials that we can offer patients up front, and it's not the last resort. So I don't know if you have anything else to add on to that. It's such a big field.
Well, yeah, I mean, I've made my career doing clinical trials. That's kind of an area of focus for me, and fortunately there have been a lot of advances in hematology. Finally, it took a long time, in medical oncology as well, and this has come directly through patients who are willing to be on trials of new medications, or sometimes new medications compared to old in a randomized way. And I think for a given patient, the patient would need to understand what the value might be, what the risk might be, and make an individual decision. We wouldn't want to coerce anybody, but we do want people to know what the options are.
Right, because it could be a better option as opposed to
Yes,
the
but you have to
standard.
always be very careful, right?
Right.
Because a lot of people go into clinical trials, a lot of patients enter clinical trials because they believe it is a better option. And I think an investigator has to be upfront and say what are the potential advantages and disadvantages in participating in a trial that offers a new drug or a new therapy.
Good to know. Okay, so right now we're going to get some questions from you in the audience, and let's see if there are a couple. All right. So, and this will be for both of you. What are common treatments for cancer, for blood cancers? I think is what the question is.
Common treatments for blood cancers can range. I mean, usually it's chemotherapy, but that can also include a pill that somebody might take for every day. It can include all the way from chemotherapy all the way to immunotherapy and transplant. So it really is such a broad range for each diagnosis.
Gotcha. There's a question here about transplant, about what it is, and does everyone require a transplant when they're
Okay, the second question is easier to answer,
Okay.
and that is no, not every patient requires a transplant. Broadly speaking, there are two kinds of bone marrow or stem cell transplant. I think today we try not to use the word bone marrow transplants, and so many transplants use stem cells that are derived from the blood or from a cord blood donor or something else. So the official term now is blood and marrow transplant. The public rightly calls them stem cell transplants. I like that terminology too. And broadly speaking, there are two kinds. One in which the patient acts as his or her own donor, and one in which you solicit a donor, or we identify a donor from family, from unrelated persons, from cord blood donors, from half-match donors, whatever. They're two completely different ideas. The transplant in which the patient acts as his or her own donor basically is a form of high-dose chemotherapy. Chemotherapy is administered at such high doses that the patient's own bone marrow would be destroyed as a side effect of treatment. And if you've frozen some away, then you can give it back, sort of like a blood transfusion, and the cells are smart. They know where to go, and they make a new bone marrow after 2 weeks or so. And that is done for diseases in which dose matters. So if a little bit of chemotherapy works but doesn't quite cure the disease, then giving more chemotherapy might cure the disease, but you couldn't do it without supportive bone marrow stored away.
Gotcha.
That's completely different from allogeneic transplant, where you're using a donor source. So what's the thinking there? The thinking there is that not only high-dose chemotherapy may be helpful in getting rid of the malignancy, but somebody else's immune system might aid the process too. These transplants are riskier, but the payoff is that you have a different immune system. And you know, actually worldwide, it's about a 50-50 split. Among the 60,000 bone marrow transplants done worldwide every year, half of them are autologous, where the patient is his or her own donor, and half of them come from a donor.
Gotcha. Okay. Question here is, there's been a lot of excitement about CAR T cells. Will that be a treatment for everyone in the future?
You can have that.
CAR T cells are currently not for everyone. Currently, the indications for CAR T cells are relapsed refractory diffuse large B-cell lymphoma and for acute lymphoblastic leukemia. And the second
refractory.
patients who have had treatment that has not worked, and
Gotcha.
so we need another line of therapy. And the second part of your question.
Will this treatment be for everyone at one point in the
So
future?
right now, CAR T cells are being evaluated in a number of different blood cancers, and so we hope that soon, hopefully, we can have approval for these indications as well. So it is broadening its a platform.
Yeah, and following my description to you of autologous versus allogeneic transplant, what this is kind of doing is a hybrid. So this is taking the patient's own cells,
Right.
T cells in this case, and modifying them so that they are immunologically active and can go after a target.
When you say immunologically active, you mean
As would have been from a donor.
like immune system?
Right.
Okay.
So it takes the idea of the allogeneic transplant, putting in an immune system that could recognize something foreign, that is the patient's disease, but it comes from the patient. So it's a very interesting idea. We do a lot of them, but it is still far from prime time. So there are a lot of risks, there's a lot of toxicity. It doesn't work for every disease. We're trying to figure out for which diseases does it work, how feasible. So these are early days, but the idea is very interesting because it takes this 50 or 60 year experience of transplant and tries to put together the two models of patient being his own donor, but doing something that the cells now recognize self, cancer, as foreign.
Right. So there's just still so much more to
There's
learn.
a lot of work to do here.
Yeah.
Nowadays, we're really working on ways to optimize this therapy by adding in different things and potentially doing interventions that can make the procedure safer.
Okay. The next question is, I was diagnosed with Polycythemia Vera. What first steps should I take to explore my options?
Okay, well, that is a disease that's kind of a borderline disease. I wouldn't call it a blood cancer, but it is a disease of the blood and bone marrow in which you have a family of cells that have acquired a mutation, and that family makes too much of a good thing. It makes too many red blood cells.
Got it.
So how does that distinguish itself from cancer? Well, a real cancer of the bone marrow would not manufacture cells that are useful. In this disease, the family of bad cells manufactures things that are very useful, red cells, but to excess. And that's where the harm of the disease comes. So there are many hematologists in the United States who treat Polycythemia Vera, but we have to treat it judiciously because it's not a disease that will tomorrow take off and produce, generally, bad cells. It's a disease where you're trying to control a family that's producing too many red cells. So our therapy is a little more judicious and careful with respect to that kind of disease.
Gotcha. Yeah, I mean, for the Leukemia Lymphoma Society, I think we consider it a blood cancer, so we have resources on that available.
Correct.
Yeah.
But you do that for different reasons. I think you call all the myeloproliferative
Right.
diseases cancer. That has some powerful imagery associated with it. But I might not call it cancer.
Gotcha. Okay. Are there any other questions that we have? Okay. Well, we're going to take a short 5-minute break and bring in Rebecca Pittenger to ask her some questions as well. But thank you so much, Dr. Schiller,
pleasure.
Dr. Young, for sharing your expertise, and
Thanks
we
a
will be
lot.
right back.